Hey everyone, we're just gonna dive in. So excited to be here this morning and talk to you a little bit about working with youth who use drugs. I think it's always as I was sort of preparing my these slides and sort of thinking about what to present, it's like a little overwhelming because I take care of adolescents and young adults. I do research and community work with them, and there's so much that I can share. So I tried to condense it into some sort of tips and sort of thoughts because some of you may not take care of youth, but have some exposure to them. So just some practical advice. But hopefully there'll be time at the end too that we can talk a little bit about maybe your experiences and have more of a discussion. I just want before I start though, just want to sort of acknowledge a couple of folks who sort of helped me in, I think, my thinking about sort of putting together these, not even these specific slides, but just sort of like how I think about youth. And so one of them is Amy Ewell, who's a child adolescent psychiatrist who works with me at BMC. The Catalyst team, which is the clinical team I work with at BMC that includes nursing and social work, and Amy. And so and sort of all of the patients that we've taken care of and the youth that I work with in the community too, because all of them sort of have had an impact over on me sort of during my career and sort of have helped sort of inform some of this thinking that I have about how to work with. So, all right. So our learning objectives are to discuss the evolving epidemiology and drug supply, to understand trends in youth substance use and overdose, and then sort of get into the meat of it and think about sort of how can we incorporate sort of practical, developmentally appropriate techniques into clinical encounters that is actually sort of doesn't have a lot to do with any specific substance, but is really like how can we approach youth in a way that sort of makes sense for them and for their families. And then talk a little bit about confidentiality, family involvement, and consent laws, and hopefully offer an opportunity for advocacy, actually, sort of at the state level with some interesting legislation that's been introduced this year that y'all can get involved in. And then hopefully talk about overdose prevention too at the end. I just didn't put it on there, but always want to bring that up as well. Okay, so first we're going to talk briefly about sort of the epidemiology. And so I start with this slide because, it seems like a little bit obvious, but many more youth report using drugs that actually have a substance use disorder. Like that is true. It's always going to be true. And we know that sort of any exposure to drugs or alcohol, it can be sort of harmful for a developing brain, but also just like for the impacts in their life, which is like what I actually care about. I do care about their brain development, but I care about sort of like what's happening to them in school and their families and their relationships. And so I really care about like that's where I can actually have an impact is sort of in those spaces. And this is really important because this means that like although we should talk about treatment, and I'm happy to answer questions about sort of treatment and what is evidence-based treatment for youth, it also really means that we have to figure out how to have conversations with young people about their drug use and about if they're not ready or in a space to stop using, how they can maybe decrease their use or how they can use more safely. How do we do that in a way that isn't sort of encouraging or condoning drug use? Like that's not what I'm talking about, but sort of also recognizing like where's the space between saying sort of like, don't use, you should be abstinent, one pill can kill, and treatment, like there's a space in between there that I think we sort of have to figure out collectively, like where we can be more comfortable. I will sort of offer there's a lack of evidence there. So some of that's where sort of this like practical tips based on sort of clinical experience over time. And so one of the first things that I think we have to do is just sort of recognize how much has changed for young people sort of over the last decade. Like certainly, so I completed fellowship at UBMC and like 10 years ago. And so just even in thinking about like in that time during like from my fellowship, like so much has changed for young people. So some of that has to do with like how they're accessing drugs. And so certainly that they are accessing drugs like from friends, from family, but also, the emergence, not just emergence, just like the presence of social media in their lives, where we know they spend sort of a lot of their time, has also meant that that's actually not just where they may be learning about drug use, but also like purchasing drugs. And so that is just like a difference that was just not true when I was sort of training. So just introduces this idea of like, how can we talk to them about where they're purchasing their drugs, the implications for like safety because of that. So that's really different. And I think is probably a difference compared to sort of the older patients or the adults who, maybe some of us are also taking care of. There are other things that have to do with sort of the drug supply itself. So some of this, it certainly, we can talk about like fentanyl, but the presence of fentanyl, I'm going to talk in future slides about, in counterfeit pills, like that is very different. Also, the potency of cannabis, like, is just a reality and has really changed things for young people, where I take care of a lot of, the patients I see do have substance use disorders, the adolescents, young adults, and they are, and cannabis is one of the most common substances or like reasons why people are referred to us, and they're using a lot of cannabis like all day, all the time. And sort of actually they will tell us about how they feel. They can tell that the potency has sometimes even changed. And so that, I think, also has implications for the conversations that we should be having with them about sort of the effects and then the potential risks of use as well. So I said, social media, one impact is they can maybe purchase drugs on social media, but they're also just sort of like on social media. And I think we have sort of increasing evidence about sort of looking at the like associations between social media and mental health. This is sort of like a growing field. And I think there are sort of questions about like what those associations, like where the causality really is. But just wanted to sort of highlight actually just a study from this year that was actually able to use sort of like national data, the ABCD study. So they're able to it's a cohort study that's funded by the NIH and sort of enrolled people sort of when they were 9 or 10 years old. And so can actually sort of really, and they're collecting lots of data. So they can really look at sort of like what is happening sort of over time and do some really interesting analyses looking at trajectory. And sort of the take home here is just that actually sort of the total screen time didn't really matter as much, which has actually been sort of a consistent finding. But the ways that youth sort of use social media and their phones, and whether or not it was sort of like low addictive behaviors versus high addictive behaviors, was associated with sort of poorer mental health outcomes. And so also just has a lot of implications. This is not going to be a talk about this. I feel like I am still sort of learning about sort of what this means. But again, it's just like, I'm offering this because this is like their back, like this is sort of their context. This is their reality. The other thing, I wanted to show a different slide about overdose deaths, so I'm going to talk through it, but one of our research team helped put this together, and I don't know how to change the background of the slides without their help, and I couldn't do it in time. But just want to highlight, which is like a sign of me getting older, right? So, or just needing a lot of help, which is also, it takes a village. But just like want to highlight the importance of like that we don't forget about talking about overdose when we're talking about young people, and that sort of certainly sort of overdose has like profoundly impacted adolescents and young adults. It's one of the leading causes of death of adolescents in the United States. And actually there was a really interesting Kaiser report that came out this year that showed that although overdose deaths sort of declined between 2022 and 2023, like they did in the rest of the country, that actually like fentanyl involved overdose increased. So it was like it was a decrease in other kinds of death, like drug overdose deaths that led to the decrease, but fentanyl involved overdose actually like continued to rise. And so happy to talk more about like maybe why that's happening and implications for intervention. But I think just like always want to make sure that we're not thinking, we're not sort of forgetting about sort of youth when we're talking about overdose, because I think how overdose prevention actually looks sort of different for them than adults. And that's partly because of counterfeit pills. And so, we know that there has been this proliferation of counterfeit pills, and it's really sort of complicated the risk, especially for young people who are more likely to use counterfeit pills than adults, which might mean that their sort of first exposure to fentanyl, like might be a counterfeit pill. It might be something that they're actually not necessarily looking for. Sometimes they are, but not necessarily. And that we know that we've sort of actually done a really poor job from a public health perspective in terms of sort of providing standardized overdose education in schools and community settings and healthcare. And so they actually like don't have this information necessarily that they need to sort of either make decisions about not using or sort of engaging in sort of other strategies that would reduce their risk of overdose or ensure that there's someone there in case someone does have an overdose. And so this is, I think, is like a particular place where things are different and important for youth. Another way that we sort of know this is sort of looking back. These data are a couple of years old, but looking at a CDC MMWR. And what they did is they characterized they looked at the characteristics of overdose deaths among 10 to 19-year-olds. And so what they found was, 84% of them had illicitly manufactured fentanyl, like after found in them after their death. The other thing that was really important in this is that 65% of these youth died at home, and most of them did not have a history of opioid use, not even opioid use disorder, like opioid use. So what does that mean? It like really tells us that like maybe these are youth who don't really actually have a use disorder. So like buprenorphine isn't necessarily going to be the response it should be for the kids with opioid use disorder, but actually sort of thinking more about like, how do we think about sort of ensuring that we're providing education, sort of non-fear-based education, accurate information to youth so that they are sort of aware of the risks and how the drug supply has changed. Okay, I'm going to keep going and get into, so these are like the tips. These are the tips. All right, this is kind of fun. So the first strategy or thing that we think about a lot is like using language that's relevant to the lived experience of young people. And as I offer this is, again, you're going to hear, this is like what I've heard from patients over the years. This is like not because I'm a young person anymore. So this is like me channeling everything I know from them. And this is a little bit different than sort of oftentimes we talk about stigma and substance use disorder, which is really important. But like, this is actually different. This is like, how do you connect with a young person? How do you make sure you're using like words that are relevant and terms and concepts that are relevant? So the first idea, and those of you who have heard me give talks before, like have seen this slide or versions of this slide, but it's important, is, we often say, and we say this actually a lot about a lot of sort of populations that are marginalized or have low engagement in care, that they're hard to reach, which I think it just sort of, I ask everyone to sort of pause and think about what it means to sort of say a group is hard to reach. We're sort of blaming them, and I'm not going to say I haven't used this term. I'm not going to say it like this isn't a lecture. This is just like, when we say a group is hard to reach, like whose fault is it? And so what if we flip it and like, what if, and I think a lot of us probably do this because I know a lot of you and I know the kind of work you do, is like we think about us as hard to reach and how can we sort of redesign care and redesign access to care for people who do have low engagement in sort of traditional healthcare so that it's more possible, so that then we're not so hard to reach. Because my experience is my patients, when we make it easier for them, like then they show up. But it just takes different kinds of steps sometimes for the young people who we care for. But I think that's part of our job. Like, it's not just, I mean, I see the work that our team does is not just about making sure we have evidence-based treatment or harm reduction, even to offer people once they make it in the door, but really trying to make sure that we're facilitating the process and making sure that they're able to access everything that they need to lead the lives they want to live. The second idea is just that the chronic disease model might be limited. So I think, and this is sort of going to be true when we're talking about other chronic diseases and sort of in general, when we're talking to young people, that's sort of like thinking about like the future, like, and what does it mean for me to be telling someone they have something that is going to be around in their life for 20 years? Like, I don't really know that actually. Like, I'm not sure what's going to be going on when they're 35 or 40. What I care about now is sort of like what's happening now, like what's happened in the last couple of weeks. And so this is a quote from a qualitative study that we did with young adults who have an opioid use disorder. And they said, none of this stuff's supposed to be utilized for the rest of people's lives. It's supposed to be a step towards to help you out, and then you can take your own direction after that. And so I think that is just like really important. This is just to say that like, we don't really talk a lot about the chronic, this is a chronic disease when we're in clinic. We're really trying to like stay in the moment and understand short-term and long-term goals at that time. And then this also means like for some people, the recovery model might not resonate. This isn't true for anyone. And this is this again, like, I'm not here to tell a young person how they should not sort of identify, like, that's not my job. It's to sort of understand how they, but that it might be true for some people, that it's like not the right fit. And so, um, this another quote from another participant in this study said, they don't want their life to continue to be defined by their substance use, including if that means being defined by not using substances. The conversation isn't just about people won't die. It's like people will be present for their lives again. And so this is just sort of like a call to sort of not reduce people to their diagnoses or disorders or like chief complaints. Like, right. This is about sort of like thinking about the person as a whole person and understanding there may be other sort of parts of sort of their identity or who they are that sort of we want to try to nurture. And I think I can think back to a patient who I've seen in the last couple of weeks for whom like this was like a real issue. Like he has grown up in a family with both parents with severe substance use disorders. Like drugs have always been in his life. He developed a use disorder when he was like in his mid-teens. He's a young adult now, continues to there are like ups and downs, but I think he was sort of saying how he was feeling like everything was about his drug use, like in terms of even the kinds of supports he was being offered, and that what he cared about was like getting a job and there were these other things and like figuring out how to hang out with friends and this other, and it was like harder for him to figure out like how to access those other sort of very developmentally normal things. And so just so that we don't sort of put people in boxes, right? That we're sort of open to the things that they might care about or bring them joy or help them find those things if they haven't been able to do that so far yet. So the next strategy is sort of centering the youth when structuring the visits. We get a lot of questions about this. So you might be tempted to just meet with the caregiver first. Like maybe they're going to give you all the information you need. You're going to see this young person. You're thinking like, they're not going to tell me anything anyway. Like they're just going to sit there. Like maybe I'll just ask the parent, like what's really going on. And so I'm here to urge you to like not do that, even when it's tempting or might make things a little bit easier. But another way of sort of thinking about sort of getting that information. It's not that that information isn't important. It's just about sort of how do we build like a therapeutic alliance with the young person. So, this is just a way that we try to do it in our program. This is, I think, what a lot of programs do. So it's not necessarily unique to us. This is sort of what we do in adolescent medicine. But I do our intakes like with our social worker, and we sort of say to our patients, we're doing this so that we don't have to ask you a million questions. I think we feel like it's more trauma informed so that we're not asking a million questions. But it also allows us to talk to, Julie and I can talk to the parent, to the patient or the caregiver, whoever's there, and sort of say like, this is who we are. Why do you think you're here? Like, what are your goals? Like, what's going on that sort of brought you here? We're able to review confidentiality sort of at the beginning and sort of like have that out front. We're able to we talk about mandated reporting right away too. Just oftentimes they know that. We just like want to get it out there. I think the way that we try to talk about the confidentiality piece is to say something like, if I'm concerned about your safety, I'll talk to you about involving other people, like your caregivers, and then we can figure out a plan. But we really try to frame things around safety and really try to, again, engage with the young person every step along the way. At that point is sort of like when we ask the parent or caregiver, whoever it is, to sort of like leave the room. They're usually expecting that. It's like never actually been a big deal. Sometimes the kid is like, no, I don't care if they stay. And we're like, no, why don't they leave? Like, we really want to be able to like, that's cool. We're glad everything, like, that's actually a nice sign that like, maybe it's going to be, a little bit easier on our end to be able to have these conversations, but like, we still want to be able to have the conversation. Things still kind of come up. But it also sort of acknowledges their autonomy. It acknowledges that like we see them as the patient, as the one who is going to be making the decisions and sort of like so it's like an empowering step for them, which is important for the medical visit, but is also like important developmentally for their life, that they are sort of like taking, some responsibility and have space to act on their own. And, I just sort of want to note that like especially in those first visits and still beyond that, like they might be totally not open and honest about sort of what's been going on. And just to say that like, that's okay. Like, I am not there to sort of like wrestle out of them, like exactly what has been going on. It's like a big deal for a young person to have to come and sit in our, what I feel like is very sterile medical setting, and then sort of share their, like the deep, these really personal things that may have been going on in their lives. And sometimes they share it all and it like all comes out right away. You don't even have to ask a question. They're just ready to. And then other times, like they're not, and like they don't want to be there and they don't want to talk, and like that's okay. Like I have to let that be okay, because actually engagement is the, like, in creating a safe space is the most important thing I can do in that, in those early days, because they don't know me. Like the day before, if we had passed on the street, like they wouldn't have recognized me, right? And then I'm like, so have you ever had an overdose? Like tell me about like that. Tell me, like that's it's just like a huge deal. And so we just sort of can't forget. Like I think sort of just like forcing ourselves to remember. So at that point, depending sort of on what's going on, like sometimes we will talk to the caregiver ourselves on their own. Sometimes that can be an opportunity to sort of like hear a little bit more about what's going on. But I would say this like usually doesn't happen. Sort of usually we sort of try to keep the adolescent in the room. Sometimes they want us to talk to their parent on the own, and they're like, I want to step out. My parent has stuff to share with you. I don't actually want to be here necessarily to hear all of it, which is, we're sort of trying to take their lead. And then we sort of invite the parent. So then we talk to the teen about, actually, I'm going to go back. Then we talk to the teen without the parent about the plan. And we sort of say, like, these are the things that we're thinking about doing. Usually Julie and I actually even step out of the room before that to make sure we're on the same page. We tell the patient in the very beginning, we're going to do that. We can make sure that we're on the same page. We come in, we talk to the patient about like what we think like might be most helpful for them. And then that way we all have consensus, and then we invite the parent back in and sort of share information. And like those components of care we can talk about involve all of the things you might imagine. Okay, so that's sort of how we do a visit. The next strategy is just sort of like thinking about when you're in that room with the adolescent, like sort of taking what we're calling like a youth responsive substance use history. I think back to sort of fellowship and sort of the different components of substance use history, and sort of like going through the different components and making sure we're reflecting everything. And I think we still do that, but have sort of evolved in how I think about how we're doing that. And why is that true? Well, it's because, like, as I was saying, sharing parts of the substance use history can be really traumatic sometimes, and that we don't know like everything that has happened, and probably not going to hear about everything that has happened. But it might be actually like really triggering or hard to talk about. And so want to be really sort of thoughtful about how we're entering that room and creating the space for them to share whatever they're going to share. We always sort of thank people for being there and sort of acknowledge it, that, that it's hard to show up, and that we, look forward to working with them. I think we really in our histories are really trying to focus on like components that are related to safety and things that might sort of have implications for sort of decisions in that first visit. As I said, we always give the youth time alone. And I think sort of this last idea of like responding with curiosity is really important, and like can just be really hard, to be totally honest. Like I think sometimes if we're rushed, we might be trying to get through things so that we get the information that we need. I think sometimes it can be hard. Sometimes some of the things we hear are like really hard. Like I still sometimes am like, and like might make you want to cry. Like, or I'm a crier. So it's like I'm sitting there and I'm like, or you might be like, how did that happen? And you're like finding yourself being judgmental. I think sort of just being honest with ourselves about like what might be triggering or hard in that visit. And really trying to sort of like, how can we be curious? Like, how can we be leading with curiosity? And so practically like asking like, what kinds of things, what are they using? Like, what are the potential risks? What might they know about some of those risks? Why did they start using? Like, what are the benefits? I think like it's amazing to watch their faces when we ask this, like, why do you like it? Or like, what's good? Or they're like, wait a second, there's a grown-up asking me like, what's good about my drug use? But like, we need to know that because, behaviors make sense and there's some benefit and there's something that is really positive. And so, what symptoms are they having potentially that are sort of being addressed by this? Like we were talking about a really highly traumatized patient this week. who was using a lot of weed. He's had like a lot of trauma. And we were like, gosh, if we take away the weed, I mean, to be honest, we're like, if we take away the weed, man, like, it's like, what are we going to offer instead? Like, what do we have to be able to offer to this person? Because, or if we suggest taking what we can't actually, like, what does that actually mean? And I think that's like, those are hard conversations to have, but like, they are like the real conversations, and it is truly the reality of the patients, some of the patients who are working. Questions about like, when do they use, where are they using? Because that does have to do with safety. It might have implications for like school performance or driving or participation in sports or other hobbies. And then, or school and getting in trouble. So those are some of the things that we're sort of like trying to understand and sort of piece together so that we like really have a picture of sort of like how they're using drugs, why are they using drugs, and sort of how does drug use like interact with their life, right? Like where is it in its place? The next thing is just being comfortable with their ambivalence. And like, that sort of means not thinking that they're lying to us, but just recognizing they're ambivalent. And I think that is something probably all of us see like a lot of the time with our patients. And I think sort of recognizing that like we as humans like can hold lots of things at the same time. And we do that in lots of other places in our life, and you can probably think yourself, I can, and I imagine many of you can, like, we can think of lots of different times in our lives that we have been ambivalent. And like, that ambivalent, it's like really hard, right? You're like, I'm not sure. And I think that is really true for a lot of the youth who I have cared for over the years. And so how can we address that? So I think, we try to offer a safe, engaging space to be with us, and then sort of offer them opportunities to be autonomous and like sort of be making some of their own decisions, right? That's what that means. They can then make some of their own decisions. And so that can be small things like in-person or telehealth. What time do you want to come in? Like, what works for you? Like, it doesn't have to be like huge life-changing things. It's just like really just sometimes just giving some choice. It might mean like mini experiments. Like, what is it like if you like, when would times work for you to like smoke a little less? Because actually a lot of them don't want to stop their use, but like might want to decrease their use, or there maybe is some impact. So can we work together to figure out like what some kind of change might look like? And we can do that together. Like, that doesn't have to be me telling them what to do unless they need some prompting, which also happens sometimes. But I think accepting that ambivalence is really okay. It also means that like we have to sort of be able to align goals for treatment, and so like I might have my agenda, but sort of asking questions about like, what are their goals? What are their hopes? What are the things that they want to accomplish? Because maybe that's sort of like the thing that we're really going to focus on, and sort of figuring out what steps make sense. Another quote from this study. It's really cool. We have medications that cannot just stop people from using and stop people from dying, but like genuinely give people a more present life. And I think for me, that's more than not using, right? So like, it's like kind of about the drug use, but like not really about the drug use. It's about all of the other things that they sort of maybe want to care about, that they care about or want to engage in. And so I think for me, that actually makes it a lot easier to deal with the ambivalence, because we can focus on the things they care about and those goals. And sometimes the substance use will like fall away, not all the time. That's like a little idealized, but sometimes, or will become less prominent. If we can sort of think about what their goals are, which usually aren't actually like not using, like usually they're about school or jobs or families or like housing or having like more, or like, where am I going to get food? I don't know. Like, there are a lot of other things that people are caring about that actually don't have anything to, or like, I mean, it's related, but like aren't actually drug related goals. Just a quick note, just to say that like youth often have other individuals or agencies in their lives. And I think sometimes if you don't take care of young people a lot, this can be a space that is where it's like really different. And so they might have other healthcare providers, but they also like might be in school. They might not be in school, but they might be in schools or different kinds of schools. They might have different, they might have employers, they might have criminal legal involvement. They might have other social service, involvement like DCF. They might have like housing case management, lots of different sort of organizations or agencies can be sort of part of their lives or part of their families' lives. Um, and so some of the things that we sort of think about as we might hear from these groups or might need sort of collateral information from some of these agencies or organizations is just thinking about like, is this like voluntary or not involuntary? DCF usually not voluntary, but sometimes is as they get older. Um, or, what has been their experience either with the agency or individuals. Like sometimes there's someone that it's been really negative, or there's someone that's been really positive, but sort of understanding the quality of that relationship is really important. Do we have a release of information? What exactly does it say? Like, what exactly can we talk about? And so, I think then developing like a shared understanding with the youth and the caregiver about sort of what those conversations are going to go like is really helpful. I will say, thinking about like DCF, which like that comes up a lot. Like we had a patient a couple of weeks ago who've been taking care of for a while. DCF reached out and they wanted an update, but we haven't actually given them an update in a while. So we have a release and it's like reasonable to be calling this person back, but I like called the patient first, and I was like, hey, heard from your worker, like she wants to talk to me. Anything I need to know before I go into this conversation? I want to make sure you knew I was going to be calling her. This is what I was thinking about saying to her. And like, she was just like, yeah, that sounds all fine. Like, thank you for letting me know. And like, that was it. Like, it actually wasn't a big deal. She's about to turn 18. And so anyway, it's not going to be an issue soon, but I think that just sort of that engagement with them is really important. So quickly, just sort of recognizing the role of confidentiality, family involvement, and consent. I sort of started to talk about this. It's just that like the importance of family. I think that although the patient is our patient and confidentiality is really important, all of our people, like all of us, like live in families, communities, social networks that have like profound impacts on decisions we make about healthcare, engaging in care, ability to engage in healthcare, like all of those things. And so to sort of think that we're taking care of people as individuals who are not part of these networks and that like their information or engagement might not be helpful, like doesn't really make sense to me. And to be honest, like as a parent, I have a 7, 10, and 13-year-old now, and like thinking about them and their interactions with like healthcare, especially as they're getting older, like I'm like, oh my gosh, like they have to talk to me. Like I'm the one who knows exactly what's going on. Oh, like this is what it feels like to be on the other side of sort of like wanting to share that information, wanting to give my kids space to sort of be their own person and engage in healthcare, which I know is important. But their social networks are also really important. And, or we're hearing from kids, my whoever like doesn't really want me on this Suboxone, or like doesn't really want me on this like antidepressant, or like my family had this really negative experience with methadone. And that's really sort of impacted like at what it's like when that person goes home and is then at home and having lots of conversations with people in their life who are like not supportive of our treatment. So we're actually like not necessarily doing our patients, I think, sort of any favors by not figuring out how to engage family. And like actually maybe we're making things more complicated for them because then they're trying to figure out like who can I trust, who can I tell what, like how do I integrate sort of this different information and advice. So, and I think that there are ways, and when we do sort of find ways to like hold at like the confidentiality like really close to what we do, but also engage with like I think it's not always easy, but like I think we do try to do that. And as I said, this is just like I think you guys have the slides. So this is sort of how we, again, at the beginning of the visit, talk about confidentiality and really try to frame it around safety, because that's what we're doing in that moment. Just so this is the advocacy note call out is that in Massachusetts, you may not know, well, I don't know if folks know this. In order for a minor to receive substance use treatment without parental consent, you need to have a diagnosis of drug dependency from 2 physicians. Did anyone know that? Raise your hand if you knew that. Okay, a couple of people know that. My perception, I hope you share, is like it's a little outdated. And that although, again, as I just said, it's really important to involve families, like sometimes it's not possible. Or sometimes maybe teenagers like going to a school-based health center and wants like treatment for like nicotine use. And usually it's nurse practitioners working there. And you know what we want? We want the nurse practitioners working there to be able to like prescribe NRT, like, and not have to like get two doctors to say like yes, and then diagnosed her. I mean, it's just, I actually probably this is not actually happening because it's so silly, like because so many people don't know this is the way it's supposed to be. But I think what would be better is to actually just like change the law, right? Like we just actually changed the law. So we got some representative to introduce like new language that would change this. And so we were able to testify at the State House like earlier this summer about this, but we're sort of also trying to like collect stories and other folks to sort of like support. And so whether or not you want to be part of like a letter with us, like signing something or like want to talk more or have stories that would be sort of compelling, it would be great to hear from you. This doesn't like negate mandated reporting, or if you were acutely worried about a kid who was, you would still do all of the things you do. It just actually is supposed to be making care more like it is for, STIs, confidential care for STIs and other sort of adolescent issues. Yeah, so please, because this just feels like hopefully low hanging fruit. Okay, all right. So then just a couple of words about overdose, and then we will have time for questions. I took a lot of slides out, so I was trying to give us some space. This is just the importance of talking about youth overdose, and just thinking about how these deaths are preventable. And so how can we be engaged in sort of thinking about preventing these deaths? So, there are a lot of ways we could be doing this better. I could talk about that sort of all day. But one of the things is that I mentioned was that a lot of these overdoses are sort of like happening at home. And so that really means like talking to youth and families about overdose and risk and naloxone and like making sure they have access to it. And as I said too, most of them don't have any actually history of opioid use. And so that like really means sort of thinking about general education. There are ways that you can sort of normalize conversations. Like this is really thinking about healthcare settings. I want to talk to all families about this. The drug supplies change, like can I share some information with you? I think always asking what people already know about overdose risk before you sort of dive in is like really important, because a lot of families and youth have been impacted by overdose. And so we don't want to make any assumptions about what someone's experience might be, because this might be a really hard conversation to have. And I think what we're trying to do is sort of suggest this can be like anticipatory guidance in pediatric primary care. And so always happy to talk more about this. Like we are sort of in our group, we actually have like a couple of grants from NIDA that would actually like we will be like piloting in primary care universal overdose prevention. So we have this like cool training that we developed with youth and families. We're going to give it to providers, and then we're going to like test it. So that's happening this fall, which is exciting. And then we've been doing some like focus group and co-design work with youth in Massachusetts and Rhode Island to adapt harm reduction materials that could, but we're also trying to do community education. So if anyone is sort of interested in talking about what that looks like, we have sort of a curriculum that we have changed many times. Each time we give it, we change it. But where we can go out, we're going out to like boys and girls clubs and after school programs and to different schools like that, and sort of talking to youth and families about overdose. So happy to talk more about that or give you information, like if you're interested in seeing what we've created. But I'm gonna stop there, and I think, okay. Yeah.
That was amazing. So while people are coming up to the mic, I just wanted to make a quick announcement, because the next thing that's going to happen is that we ask all members of MASAM to stay here for 12:15 to 12:45, our annual MASAM board meeting, and that everyone is welcome to. We encourage you. We're going to review results of the election, go over the Barbara Herbert Award, get our treasurer report. So stay here if you're interested. And Otherwise, we'll have time for Sarah's questions till 12:15. That's going to be the last time we are all together in this room as a conference. And so we're going to go to lunch, and then everyone's going to come back into these 3 breakout rooms. And remember, we intentionally built this 45-minute period after that. We're ending early no matter what, but really to be able to mingle and get to know each other. So please take advantage, and I'll turn it to Sarah.
Hi, Sarah. Thank you so much. Heidi Ginter. I am unfortunately a mother who is dealing with a 16-year-old who's got substance issues right now. And the question I have is related to individuals who have the privilege of having a self-driving car and utilizing that as a way of not having to find an alternate ride home. Do you have any thoughts about advocacy around youth using self-driving cars to avoid having to abstain when they're out?
So I have not thought, you're watching me like hear about an idea for the first time and not having thought about it. I think then I would, and I don't know a lot about self-driving cars actually too, so that I'll just throw that out there. But I think then I would think about, then maybe that's not the thing to be providing the counseling on. It's sort of like thinking about all of the other, thinking about the other potential risks and harms. And so that's where I think I would probably go with that. Yeah, I think that's probably what I would do. It's sort of like not engage in the back. I think it's like what I'm imagining is like not engaging in the back and forth about that, but sort of trying to step back for that, because that doesn't feel like it will be a winning, like that wouldn't be a winning strategy. You know what I mean? Like you'll just be battling about that.
Yeah. So I'll just say one other piece of it, which is what it means is you get home safe.
Yeah.
And you don't learn that
Yeah.
you should have called an Uber, or you should have
Yeah.
called mom, or you should have called Lyft. What you learn is that all we need to do is make sure we keep taking the Tesla.
Yeah. I mean, I guess it's also, there could be like restrictions on using the car, I think that's also like, that's, cause it sort of similarly, like the way we recommend to families that, if their kids have cars, like they're not allowed, they're not able to drive if they are intoxicated, or if they're sort of not able to show some, and so not letting them drive, which might cause other, but and you're trying to keep your safe. So you do what you need to do.
Hi, Sarah. Thank you so much for your presentation. It was amazing. Nadia Schessler, I think everyone knows me by now. Wanted to see if you are involved or have thoughts about substance use education reform in Massachusetts in the schools. I'm not really in the know, but I was curious if you had thoughts about that.
Yeah, I am not. So I will say that I've been that had not been a focus until like the last year, where we've been doing more community education and focus groups and working with some local high school students. And I think they have sort of been like, oh, wow, there's a lot we need to do, I think, in this space. So I've not been involved in like general substance use education reform. There are actually also a couple of other bills that are related to providing overdose education in schools and naloxone access. There's like a handful of them. They're all a little bit different. We've actually we've provided some testimony on those as well, with and we've done it in with college students and med students and youth, to sort of like say this is, and some of those are exciting, and again, happy to like share more information about those bills if folks want to like submit their written testimony, which would be awesome. One thing that I will sort of add that is like this is like in the last month I've been thinking about it, but it's because of some of these focus groups we did actually in some youth in Holyoke, where we heard from them. Like, I think sometimes when we think about substance use curriculum, we think about like, okay, we're going to teach them about like cannabis and how it works and what the risks are and why they shouldn't do it. And these youth were like, yeah, but like, actually what I want to hear about is like, how does substance use like affect families and communities? And like, where does drug policy come from? And like, tell us more about the drug war, and like, tell us more. That I think like we have, increasingly, but probably, later than we should have been having conversations sort of in our professional spaces, but like they're actually eager for that too. So I've been thinking about substance use curriculum about like not just teaching them about drugs, but like actually how do we teach them about how is it sort of integrated into conversations around like policy and sort of consequences of policy too. So if you're excited to talk more about it, like I'm just starting to like think about that.
Michael Beer of Boston. Thank you. it was inspiring, and I think there's nothing there that I can't take to my adult population. I mean, I really heard a call to center the individual and empower the individual and respect the individual. And, you know, it's hard work, and I respect what you're teaching me. A side note I was thinking about asking. So we have this money coming from BSAS that requires that I fill out some, you know, data and send it back. And I'm wondering if that's something that you would need to do for pediatric population, and what it's like to be actually doing what might be overly intrusive or harmful questioning.
Great question, Michael. Thank you for that. We do, so we also have, you know, BSAS funding through SOR, like, and then, but also have like the OBAT, like contract too. And we find it problematic, to be honest, like it is hard because I think it is, and it is sort of not trauma informed. And I think BSAS knows this. I actually think there's sort of like a lot of those systems really have been set up for adults, and like, what about the youth with cannabis use disorder? Like, where do they fit in sort of the treatment system? Like, how do we support in primary care or general health settings, taking care of people who have other kinds of use disorders? And we don't really have a system for that. And I think especially for youth, that's like particularly relevant. So it's like two issues. It's like both like the data collection is an issue, but then also sort of like the system, like the treatment system is really made for, the primary care treatment system is like really made for adults. So definitely some, yeah, work to be done there.
Hey, Gentina Mitchell, I work at the Mass General Bridge Clinic, among a couple other places. And I've seen particularly at Bridge, some of the just different substances that youth and young adults use. Like, I had no idea what 7-OH was until I had a patient come in to talk about it a few weeks ago. Do you have any recommendations on sort of where to get information about some of those less common substances and what's in the youth drug supply and how to treat them?
I kind of think probably asking them is the best way. Like, I don't know that we have like a good enough surveillance to, because I find myself in the same, like, I'm not perfect at this and I fall behind, or I don't know what, you know what I mean? So I'm also always learning. So I think that's the curiosity and asking them, and like staying pretty humble about like realizing that they're the experts in their own lives. So that would be my advice. And like finding ways to share. I mean, I do often think like, what are, I don't know, like ways that people who take care of youth could be connecting differently, to be sharing sort of like that cutting edge, or like, this is just what happened to me last week, or this is what I heard about last week. Have you guys heard about this? Like that, those kind of networks, I feel like would be really helpful.
Hey, I'm Shota Yuasa of Boston CTC. I'm interested in knowing about a minor's access to naloxone in our state.
Yeah.
So I'm assuming that the standing order that we have in pharmacies does not apply. You can't be a minor, walk into a pharmacy, a commercial pharmacy, and just get Narcan.
And just get it. Okay, you can. Sure. So I'm so glad you asked that. And actually, we have a frequently asked questions slide. If anyone wants that, I can like send it to them, because there are a lot of things that come up about like naloxone access and youth. So no age restrictions, like we can prescribe, they can get it over the counter. I don't know if they actually, if anyone wants to do a secret shopper study, I really want to do a secret shopper study about this. But they should be able to get it. And then there's no, you can use naloxone the way that you use for adults, like everything is, it should just be the same. My guess is that might play out differently if the minor walks into a pharmacy and asks for it, but it all should be the same, which is actually really important for youth to know too. Like, we've gone to some sort of like after school programs, and there's been like a lot of questions, or they had been sort of hesitant to recommend to their youth that they go get naloxone, because they thought like they weren't sure whether or not it was okay.
And how about public schools? Do you know of any nurses, school nurses or counselors in this state in public schools that hand out Narcan?
Not that hand it out. This has been sort of like a really important actually space in terms of advocacy. Like some of the regulations were just like updated because it used to be that only the school nurse could sort of have naloxone in their office and administer it. And that you could carry your own naloxone as a teacher, but, and then administer it as like Good Sam, but like you couldn't, like in theory, like access the school naloxone and give it. I mean, hopefully no one would actually do that if it's an emergency, but that was, so that has changed so that people can be sort of trained to be able to use the naloxone that is like on a school campus. However, and students should be allowed to carry it, but like some schools we have heard have told their students that they're not allowed to carry it. So there really is like an and then there are these bills that would sort of allow for standardized overdose education in schools teaching about opioids and like overdose response. They all are a little bit different, but a more standardized approach would be really helpful. And actually like data collection too, like actually like other states like Connecticut, I think does a nice job of actually sort of collecting information about sort of overdose related incidents and naloxone in schools. So I think it'd be really nice if we had like vending machines in schools, for example. But
Hi, Elizabeth Langmore. I'm an addiction psychiatrist with BHN at Holyoke OTP in Springfield also. And I don't work with kids. Can you hear me? But obviously young adults, 18 and up. And I really, awesome talk. Thank you. And what really resonated with me, and I'm kind of like forming these thoughts in the moment, but in terms of like the approach of developmentally adolescents being, you know, in the adolescent stage, and many of our adult patients are developmentally still very young, and looking at things through like an Ericksonian framework where identity versus role confusion, and then how that plays out depending on what phase the patient may be in, and then sort of anchoring ourselves there. And then from there, what you said about building, you know, sometimes you don't even talk about the drugs at the visit. You're talking about what is the good stuff for the positive reinforcement. And going back to Dr. Suzuki's talk, I truly believe that someone who's doing well in recovery and spending a lot of time doing those things and not necessarily talking about, oh, I'm not using drugs, or this is what tobacco does in my brain, or this is, you know, like you're building those networks in a way to make them salient. And so that the other stuff is not, you know, so out there. So I guess my question would be, I heard you talk about qualitative studies and getting the stories from the kids. How would you recommend that those of us in the adult world get involved in that kind of advocacy or kind of data collection?
Yeah, I mean, we should talk. I'm always really interested in that. I think actually maybe increasingly, I don't know, like quantitative data is so important, and yet stories are what move us. And so either qualitative studies or more community engaged work, or like storytelling too, I think can be really, I don't know if anyone, I don't think she's here, Megan Perry. I don't know, I'm going to call it Megan Perry if anyone knows her. She's this woman who is on the South Shore and is doing some like, has this consulting group and is doing some really interesting work around storytelling sort of in recovery and harm reduction. And so I would say maybe reach out, because I think that's where, I don't know, trying to do more of that. And I think actually for youth who with opioid use disorder who are on methadone, it's really important. Like methadone, I mean, that's another opportunity for advocacy, is like, how do we sort of make access to methadone more developmentally appropriate? And like under 18-year-olds in theory can get it, but I've never had a patient who's been able to sort of access methadone. And the reality is like methadone OTPs aren't necessarily the right like developmental fit. And even for young adults, sometimes it's really hard. So like, could we have a system of sort of methadone access for adolescents and young adults? You know, I think one of the challenges is sometimes like this, like, I hope you now know I'm not like a callous cold person, like the numbers are different and smaller. And so it can sometimes be really hard actually to sort of advocate for like a smaller group of people, even though they are like incredibly in need of our like advocacy and support. But that it's like not the overwhelming, you know, and so anyway, sorry, I went off on a tangent because I didn't get to talk about methadone, but I always like, I'm like, we talk about youth, like access to youth methadone. So, but be in touch. I'd love to talk more about how to do that.
So thank you. That was awesome. And your tangent was my question. So,
Okay.
so I'm Dave Tortorella. I'm currently working in a methadone clinic, also a pediatrician. So awesome.
Cool.
So I'll blame me. So what can I do? Every place I've ever worked has been 18 and up. So
Yeah.
let's just say that's my fault. What can I do to help
Oh.
expand access outside of Boston?
I mean, Phoebe might have an answer. I mean, the regulations have changed, so it should be easier. So it might be advocacy within your own organization, but I think Phoebe has an idea.
Well, the first step is just call the methadone clinic that's closest to you and see if they can.
I work at.
Oh, okay.
Yeah.
Oh, so,
So-
cause
so-
like, we make exceptions sometimes if there's so anyway, we'll talk.
Yeah,
Okay, okay.
That's what this is about, like these connections. Last question. Last question.
Hi, I'm Shraddha. I'm currently an addiction fellow at Mass General. This is really amazing. As someone who's like, I did internal medicine residency, and so I'm like less familiar with, and probably less comfortable with like youth drug use because their brains are developing, and so the conversation is a little different. I'm curious around advocacy related to like marketing, like the nicotine and tobacco lobby and like the alcohol industry are like so, and also with the age of social media, everything is like so powerful, and like the way products are designed to like be more appealing to young people, whether it's like vapes or like, cocktails in a can. Can you like talk more about advocacy at the population level while also trying to preserve like the autonomy of the young person who is at liberty to like do what they want, but also it seems like that area of prevention is like probably more important for young people than adults. So
Yeah. Okay. Great questions. Okay. So, and sort of just, yeah, like I'm not an expert in sort of like marketing, and that's not exactly what like my researcher work has done, but I will do my best to answer. And I actually think this is really important. I was reading this morning. There was like a new report released by HHS earlier this week about vaping and sort of the crisis in our country. And I would say that has anyone read it? Okay. There was a significant, a lot of it was about law enforcement, a lot of it. And I think that's like maybe a missed opportunity because it was about like law enforcement and like stopping vapes that are coming from like outside of our country into our borders. And so I think that that's important for us to know though, because like, how do we as addiction professionals like want to show up and provide the kind of advocacy around thinking about holding companies accountable or sort of making sure that youth have what they need to make sort of safer decisions. Like that's where, but we have to be showing up so that it's like not overpowered by other messaging of the moment. And we've been effective at that. The other thing that a couple of other thoughts, like one is, interestingly, some of these focus groups we've done, we've heard a lot from youth about how actually they don't always believe influencers around substance use related messaging because they think they might be being paid by companies. Even if the message is to quit, they're like, maybe they're not quitting. Maybe they're going to vape as soon as they've like done some message around quitting. So I think like there is actually that, to me, I heard like an opportunity. And to me, for the way we're approaching it is really trying to partner with youth to understand the messaging that is most relevant and resonant for them. And so I'm really interested in actually figuring out two things. Like one is sort of how do we have conversations with young people about how they are sort of processing and getting information from the internet, because it's not just social media, it's AI too. Actually, like a lot of youth are going to ChatGPT, right, and sort of asking health-related questions. So it's the internet or it's media in general, and asking them about that so that we can be involved in sort of how they're processing information. But then also the way we are like on a very local level doing it, trying to think more about like peer education but like co-development of information with peer educators and sort of like having young people actually like tell us what is important, what would help you, and then like how can you be teaching each other. So that's like very like that's how our group is sort of trying to. But thank you. I'm always happy to talk about this like all day. You can probably all tell. So feel free to, my contact stuff is sure somewhere, I'm sure, and always happy to talk more. But thank you. And I hope you enjoy the rest of your day.